there's no food today's session. Yeah, I think that misfortune is rather honestly rather fitting for because as today's topics about like obesity and food and semaglutide. So the topic for my today's talk is the real world impact of semaglutide on cardiovascular risk factors and health expenditure. So here's before I go into that, I want to introduce myself. My name is Yuntian. I'm a second year PhD student in the CBB program. So co-advised by Dr. Xu and Dr. Lu, and my research focused on EHR analytics and clinical NLP. So here's the outline for my for the talk. So first I'll spend maybe, I don't know, a significant amount of time for the background introduction, and then I'll go over some the main research questions, and then the event study design, and I'll show some temporary results and then discuss the limitation and next steps for this study. So I want to first throw some numbers when I introduce the obesity. So 40%, this is the prevalence of the obesity in adults using the most recent enhanced data. So 4 billion, that's the number that's projected by the World Obesity Atlas in 2023. That means 4 billion people by 2035 would be affected by obesity, and 1.4 trillion is the annual cost, using on all the obesity related condition and all kind of obesity related expense. Also, obesity is kind of related to diabetes. Just give some more background for the correlation between obesity and diabetes, since the drug that I'm about to introduce has multiple effects on these disorders. And as also you can see on the right-hand side, also an increase. Oh, forgot to introduce the trend that you can see the obesity trend goes up from 2013 to 2023, and also the severe obesity trend also goes up. The same goes with the diabetes. So with that, I want to introduce the semaglutide, which is the new maybe the new blockbuster in the market. So it's developed by Novo Nordisk. It's a GLP-1 receptor agonist. So the basic mechanism for this drug is that it mimics the natural GLP hormone. So it increase the insulin secretion, and which would help you reduce the blood sugar level, and it also helps slows the emptying process for your stomach, which means, and also you reduce the appetite through CNS, so which means you feel less hungry, craving for food. And on the right, you can see the timeline that for semaglutide of the FDA approval for this kind of drug. So in 2017, semaglutide was first approved for type 2 diabetes as the brand name Ozempic. And then 2 years later, its oral formulation got approved. And then 2 years later, Wegovy, which is then people realized that this drug has great potential in other health disorders such as obesity and also cardiovascular conditions. So 2 years later, Wegovy also got approved for obesity, which is a great. It's a huge deal in the pharmaceutical industry. So so semaglutide has a huge, like I said, has a huge success in the randomized clinical trials. That's why it got approved by FDA. So here I listed 5 main trials that it had been conducted. So first is the SUSTAIN trials. It's I think it's conducted for type 2 diabetes first in 2017. And then the STEP, I think that's the trials that they tested for obesity, for weight loss. And then the SELECT trials, which which I think the results got released last year, and which is also a big deal in cardiovascular diseases because it showed that semaglutide can also reduce major cardio events. So, and also some other like more high dose semaglutide formation. So the takeaway is that semaglutide helps the clinical outcomes substantially and very effectively. So around 1% reduction in HbA1c. This is a metric where we use to evaluate the blood sugar level. And that's a significant reduction, and 10% reduction in weights, also very amazing, and also 20% reduction in the MAC risk. So beside the clinical outcomes, not only for those biomarkers, semaglutide also got huge success in the market. So on the right is just a screenshot from my Google, and it shows the market the stock price for the pharmaceutical company that developed this drug. As you can see, in the past 5 years, stock got rocket high. Maybe not as good as Tesla, but it's that's huge. And on 2023, the revenue for Ozempic was $14 billion, and Wegovy is $5 billion. And it was estimated this year the whole semaglutide market would reach around $30 billion, and maybe it would reach 50 by 2019. And here's on the right hand side, it's the x-axis is the sell for different blockbuster drugs, for different those popular drugs. The x-axis is the sales in 2022, and the y-axis is the sales for those drugs in 2023. So, and the size for this dot and this circle, the area shows the sales growth. So for like the semaglutide that treats type 2 diabetes, you can see over here is ranked I think the second or third in the past 2 years drug sales. I think this one is used for cancer, and this one I have no idea, but yeah, it's really a huge success. And for the relatively new Wegovy, we also have we have it on the rank, but it may not seem as big as the other popular drugs right now in terms of the absolute sales value, but look at the growth now. I think it's the second biggest fastest growth drug in the market, as you can see here. So like threefold as compared to the previous year. So I not only make a lot of money, but it also transformed the whole industry. So it sparked the so-called GLP-1 revolution. So you may wonder in the last slides, because I said it was the second biggest growth in the market. So what you may ask, what is the biggest one? It's actually its major competitors drug, tirzepatide from Lilly's. And also the price for that for Lilly's goes rocket high. So some more background for this drug. I think, so since the drug is so popular, so it actually went through some supply chain challenge. Since the end of 2022, there was extraordinary demand for the drug, and the drug maker or the pharmaceuticals were not able to actually meet that need. So that leads to a lot of people actually, so when like the weight loss semaglutide was out of stock, then people, go for the Ozempic, which is actually for diabetes. And then when Ozempic was also out of stock, then they go to the black market for, the semaglutide, this kind of drugs. So also there's also a huge debate going on about the insurance coverage on these drugs. So semaglutide is pretty expensive. So for a monthly dose, for a monthly supply for Wegovy, it's over 1,200. Similarly for Ozempic. So like definitely for weight loss for Wegovy, many healthcare plan doesn't cover that for their beneficiaries. So that leads to a huge amount of out-of-pocket expense for patients. But like I said, in the trials, semaglutide was demonstrated to be very effective to, improve all the biomarker outcomes and the clinical outcomes, biomarkers. So like the people from pharmaceuticals and also many researchers speculate that the potential long-term costs, it can lead to the use of like the initiation of semaglutide. Although it was expensive, it might lead to a potential long-term cost saving because semaglutide can alleviate any health disorder or problems related to, obesity or type 2 diabetes.
第二阶段这个计划我们已经
我没有特别不用等哦。
Yep. So they actually they speculate that the average month's cost, like I previously mentioned, the 1,200 monthly cost for semaglutide may be offset by reduced the reduce of complications, other complication, or a future lower hospitalization rates, outpatient visit, healthcare utilizations, and also the decreased concurrent medication needs. So I know this is an NLP interest group, but due to the project, the progress of this project, we don't have many substantial NLP content in this talk, but I'll try to incorporate as much as like NLP related content as possible. So the background really boils down to one question. So is semaglutide all you need? So I use ChatGPT to create these two figures. On the left-hand side, you just use the prompt, create an image about semaglutide is all you need. It actually gives a good comprehension about semaglutide in terms of it understand this issue, like semaglutide is all you need, in twofold. One is the money, like on the right, on the left is the money, the healthcare expense, and on the right is the medicine, is the clinical outcome. So and on right hand side, I put more like hint in the prompt, like I add some analogies saying that like semaglutide now is the groundbreaking and foundation work, or it seems versatile. It seems a panacea. It works for many tasks, health disorders, just like transformer or attention. And can you just create this figure? And this is what ChatGPT gave me. And yeah, just a little fun for this talk. Yeah, Actually pointing this attention head to like different, to some nonsense. I don't know. Actually, I prefer the first figure. So, like I said, it's attention is semaglutide all you need. That question is not like formalized. So the real research question now boils down to in real world, what is the impact of the initiation of semaglutide on healthcare? Because we've seen so many trials outcomes. We speculate that it can theoretically it can reduce the cost, can help patient to get better health, but is that really the thing in the real world? So we have to so dividing the outcome into two parts, the clinical outcomes and also the expenditure outcome, we have the two following questions. So the two hypotheses. So initiate semaglutide improves the relevant biomarkers outcomes. By biomarker outcomes, we choose the weight, which is the most relevant for those weight loss drugs, and blood pressure measurements, which are related to the cardiovascular outcomes, and also HbA1c for type 2 diabetes and total cholesterol, also related to cardiovascular diseases. And also the second hypothesis is that the initiation of semaglutide actually reduced the health cost expenditure by lowering future need for the hospitalization or the need for utilization of healthcare. And we also stratify those expenditure outcome by their visit type, inpatient, outpatient, and diagnosis code. So to answer this question, we have to, this is a data source we have. So like I said, our outcomes of interest are two-folded. One is for clinical, which is those biomarkers, and one is expenditure, which is related to the healthcare expenditure cost. So for clinical outcomes, we have to use the EHR data. So this is the EHR data source we have. We have two regional large health system EHR data. First is the New Haven Hospital EHR. It's in OMOP. It's from 2013, and it covers 3 million patients. And the second one is the Sentara EHR. So it's also in OMOP, have the similar time frame and covers even more patients, covers over 7 million patients. And I think also there's also a good point for this EHR because they are both the dominant health system in their region. So we got pretty representative data using this, and we got pretty representative results using this data. And in terms of expenditure, we're going to need the claim data. So these two data sources are kind of like separated by the purpose of use of this data. So for EHR, we get more comprehensive variables. We got more track of the patient, and we are more confident in the data. We can even go back to the chart to track the patient to see what's going on. So we have more confidence in the EHR data, but we do need but EHR data don't have the cost information or the expenditure information. So that's why we have to impute those expenditure information from the claims data. And as for the claims data, we have the Medicare data up to 2019, and we are getting the access to the market scan data, which would help us to get a more like robust and reliable estimates for those expenditure results. And the way to link this to data is using diagnosis code. So in EHR data, for each visit, we have the primary diagnosis code. And for claims data, we also have that. So the way that we try to combine this together is that we aggregate using claims data. We aggregate like for per diagnosis per ICD-10 code, for example, what's their like monthly expenditure, and then we merge it with the EHR data. That's so we also have the diagnosis code information, and that's how we acquire the health expenditure estimates. So I'm gonna introduce right after that the data source description. I'm gonna pretend to be a rudimentary economist and try to introduce the event study. So this study design is actually very common in economists and finance and public health. It may not as common as in clinical or in computer science or statistics. But it suits for the treatment effect estimation where all the units in the panel. So by panel that means longitudinal data. So like the econ people and biostat people use this term interchangeably. So that means we have longitudinal data. So each patient, each unit may have multiple measurements or multiple estimates. So the event study is suitable for the setting that we only focus on patient who got treated, but we have the data that for those treated patients, we have the data before their treatment and after the treatment, and we only use that information. So some other motivation for using this study design, because that allows us to estimate whether the treatment has an effect on average. We can have multiple dynamic so-called causal effect regarding the event or regarding the treatment, and we can also test for pre-train. By pre-train, it means that all the time periods that's before the treatment or before the events. Here's the formula for this specification. So I would not go into detail, but I'll try to explain it as I think maybe in a minute or two. So consider a panel of like I units. So by units, it's actually just unique patients. So and those outcome YT is observed for 1 to T periods. That time is calendar time, so it's not relative to any like anchor point or index date. So it's just like, for example, January to December. And alpha hat I and beta hat T are the unit and period or time fixed effect. So basically we are trying to fit a two-way fixed effect model here. And the K denotes the relative time to the events. Here the events is the initiation of semaglutide. And we can estimate the gamma, and then we try to use some weighting scheme to finally estimate the treatment effects. Here's also, I won't go into this topic in details, but it's just that we cannot, using this study design, we cannot be too greedy. So we cannot both control for the pre-train and also use it for the dynamic treatment effect estimation. We have to sacrifice something, or we have to use some alternatives. So here's our 3 solutions. Each one of them may be correct. We don't know exactly what is the right model to do so. But so these 3 solutions each holds a very strong but different assumptions. we want to use, we apply these three methods, but and hoping to get some consistent results. So if the results from these three models that holds different, that's under different assumption, if these results are stays consistent, then we're confident in our results. So so luckily we get the consistent results, report the random effect models results. So here's the flow chart for this event study. So we begin with the year chart data, and then we go from 2015 to the end of 2014, and then that leaves us with 3 million in Sentara data and 2.7 million in YNH in New Haven Hospital. And then we find for each unit, for each patient, we find their first visit day in that period and last visit day in that period. So that's that's the way that we make sure that those patients are actually regularly documented in the health system, and then we are confident about their data. And then we, among this period, we find all the patients who had at least one semaglutide order or started semaglutide order, and we find the very first day as the index day, which means that's the day that this the event started or the treatment started. And that serves our as our index day. And applying these criteria, that leaves us with 40,000 patients in Sentara and 64,000 patients in Yale New Haven Hospital. And then we apply an even more strict like criteria to make sure that those patients have regular healthcare utilization, and we are confident in their data. By that I mean we require for each. So you can see we have the index day here, and we as for the K that I just mentioned in the specification, we have a relative time period in 6-month units. So here we chose in total 5 relative time periods, and then we use the -1 as a reference. That means that like 6 months before you started the semaglutide treatment. And then we require, so for this whole 5 6-month related periods, we require each patient has at least 1 visit with weight measured to be included in the final cohort or the baseline cohort. And that leaves us 5,000 eventually for Sentara and 11,000 in Yale New Haven Hospital. And this is the baseline patient characteristics for these 2 health systems for our baseline cohort. You can see the gender proportion and the race, ethnicity distribution, and also other characteristics are pretty similar across the 2 health systems. And we stratify the baseline models by type 2, by their history of type 2 diabetes, defining by do they ever have the type 2 diabetes diagnosis code before the initiation. So by that, we are hoping to stratify, to get a hint of the purpose of the semaglutide use, because we know that for diabetic patient, they may use semaglutide for type 2 diabetes, and for non-diabetic patients, they may use it for weight loss. But we don't know it for sure, because like I said, we mentioned the off-label use of semaglutide, so we can't really know it for sure in our data. So this is the biomarker outcome event study for the biomarker outcomes. So given the baseline cohort, we have in total 5 relative periods, and to estimate the effect for those biomarker, we require for every biomarker outcome, they has to have at least one measurement in these 5 6 months relative periods. So this is the results. So we pull the results together for the 2 health system using the inverse variance weighting methods. And you can see in terms of weights, after I think for period 2 is 18 months. So after 18 months, which is also similar to the trials length. I think for STEP trials, it's 64 weeks, which is like more or less. So for weight loss in the real world, the dynamic treatment effect at period 2 for the overall population, it's 4%. So for example, if you that means, for example, if you weigh 100 kilograms at the baseline, that means after you started semaglutide, no matter if you started, I mean you're prescribed semaglutide. Doesn't matter if you're taking it, or if you adhere to the prescription. That means in general, it gets you like 4% reduction for the weight. And that's even more for non-diabetic group. That's because that subgroups may use it for weight loss. And that's comparable, actually comparable to the randomized controlled trials. In trials, I think most trials report from 10% to 15% reduction. In real world, that's what we observe. And for systolic blood pressure, we see a significant reduction. For HbA1c, which is the biomarker for diabetes, we also see significant reduction, and also for cholesterol, we see significant improvement for those outcomes, but just not as good as what trial demonstrated. So this is the plot represents the dynamic treatment effects, and if we just pull them together, average it. So we fit another model, so we don't have the in total 5-6 month periods, relative periods. Instead, we have a binary treatment indicator to fit them to fit into that model, and this is what we got from the model. So on average, so for weight loss is 2%. For blood pressure, about 1 I think it's millimeter per mercury, and for HbA1c, around 0.4 reduction, and for cholesterol, about 10 reduction. So that's it for the clinical outcomes. And for expenditure outcomes, we are the study design might be a little bit different. So because when we look at the clinical outcomes, we have to really see those measurements to get the results. But here, expenditure, if I didn't show up in the health system, that means we assume that there's no expenditure because there's no health utilization, and there's nothing that we can estimate for. So here, we don't need that. We don't need patient to have at least one visit in each relative periods. So, but we do summarize those patients' diagnosis, following diagnosis code at the patient month level. And then we merged by the claims data estimates like I introduced before. And then we get the estimates for each periods. And here's the results for the healthcare expenditure. So we can see that the total expenditure actually goes up. So so this is I stratified by visit type. So for total expenditure, it goes up, and for inpatient expenditure, it goes up, and for outpatient also goes up. And if we look at the binary treatment effect, the monthly, the average monthly expenditure for those patients actually increased increase in general by 150 after they used the semaglutide. So that's not what what we learned from the pharmaceuticals or from the projection of healthcare leaders or of physicians. And note that this expenditure does not include the cost for the drugs. So these are just the following visits estimated expenditure. So that does not covers the drug cost. So if we do believe that the semaglutide can reduce the following healthcare expenditure, or at least the cost, or at least the utilization, the visit number, then we must see a decrease in terms of this estimation, because we have remember we have a 15,000 annual $15,000 gap to feed. But here what we observe in the real world data is that the expenditure actually went up, and we keep seeing that patient using more healthcare service and having more diagnosis code, which means their outcome may not be like entirely improved. So I actually have a slide about the conclusion, but I decided to skip it in the last minute, because I don't think that's, so the thing about semaglutide is still very tricky. We haven't concluded anything yet, so it's not the estimation. It's just what we observe. We try to be very cautious, but that's what we observe. We haven't framed it as a causal relationship or any causal effect. Because first, the expenditures estimation is not perfect. So I think right now we're just using the Medicare data, which is up to 2019. But once we have the market scan data, that we would have more reliable estimates about those expenditure per diagnosis code, and then that would provide us more like robust estimates. And also there's an issue about missing data and selection bias, because we put pretty string criteria for cohort selections, right? We have to be selected in the sample, they must have like at least one visit per like 6 months. That means we are biased to the patients that who goes to the healthcare system like at a regular basis. And also for the event study, the estimation has its own shortcomings, which is the short-term bias. So that means that the binary treatment effect is biased to the short-term effect. So that's why let me use the weights as an example. That's why you see after 18 months, the overall weight reduction, the weight reduction for overall group goes to -4%, but at this related time period, but on the average just 2. So and that's just the drawbacks for this study design and methods, and we would come up with a more justified way or robust way to deal with it. And also, I think for the next step, we would put more effort on the causal effect. So right now, using event study, we are just looking at the treatment group, so we don't have any control group. But after maybe for the next step, we would add control group. You maybe using propensity matching, and also for causal effect, we're gonna try to find instrumental variables to identify the causal relationship between all this semaglutide clinical outcomes and expenditure. And also right now we're just using the structured data. For next step, we're gonna mine the unstructured data like nodes, which would help us to do the subgroup identification, which means that right now we just treat all the patient use semaglutide together, but they use semaglutide for different purposes. They may use it for type 2 diabetes, or they may use it for obesity. But now, just using the structured data, we are not able to really differentiate those groups. But we may be able to do so using the dose information and the brand name, but like I said, there's the off-label use period, so we cannot really tell. But if like physician know this in the clinical notes, maybe saying that, oh, I prescribe Ozempic, it's original for type 2 diabetes, but we are out of stock for Wegovy. I just prescribed it as per patient required. Then we know this semaglutide was actually for weight loss, and then we can sort of better classify all this use for semaglutide. And also we using the unstructured nodes, we can better understand the actual drug use, if the drug is expensive in the pharmacy, or if the patient are actually taking those medications. And also we can use it to untangle the social determinant of health to understand why like a certain patient prescribed less, and perhaps why certain patients has more semaglutide prescription. So with that, I want to thank my advisor, Dr. Lu, Dr. Ablak, and Dr. Xu, and also my colleagues, Dr. Kim and my collaborator, Teddy. And that's all. Any questions? Yep.
How are the health costs of patients who do better, like maybe who survive more? They're getting more healthcare.
Oh yeah. So yeah. So we do impose like, so there are no patient dying in our cohort, because we let me put this back. Let me see. I'm not sure. It's not show on the screen, but anyway, so we for the, I don't know if you remember, for the flow chart of this the cohort selection, we first define the observational period, and then for each patient we define the last the first visit time, the first visit and the last visit in that observational period. And then we make sure that they have active hospital visits, so they're not diseased, or they're not, they don't belong to like lost follow-up categories. So that's why we make sure that these are patients who are alive and have regular visit to the health system. And that's also the reason why we may have suffer from the selection bias. Yep. All right. I guess that's
NLP.
Oh yeah. That's for the next step. So I'm this talk, it actually happens sooner than I expected. So for this project, we are gonna do it like after maybe this preliminary work, but so that's so it was supposed to be a combination of this analytics, statistical modeling, and then also with NLPs or large language models help to for this project. But just that this talk just happens sooner than I expected, so we don't have the NLP analysis or work done yet. So yeah. All right. I guess that's it. Thank you everyone for attending, and hope you have a good rest of your day. Yeah, thank you.